Go ahead.
Hello, and thank you for joining us for today's Great Challenges live event. My name is Kavita Patel, and I'll be moderating today's discussion, which will run about 1 hour. And for way of background, I'm a fellow and managing director at the Brookings Institution, had worked previously in the Obama administration on health reform, and am also a practicing primary care physician. And this session is part of the Great Challenges program, sponsored by the Robert Wood Johnson Foundation. The goal of the Great Challenges program is to take a look at the most complex problems in health and medicine, issues that cannot be solved with a magic bullet or a one-shot cure or policy. Our current focus is on the natural overlaps and co-indications between the Great Challenges. We'll be taking questions from viewers on Google Hangout, Facebook, and Twitter. We're on Twitter at TEDMED. So just tag your questions with the hashtag Great Challenges, and we'll do our best to answer them in the time we have together. Today's focus is on whole patient care, the role of the patient, and the complexities all of the members of the patient care team face when it comes to effectively managing chronic conditions. We are delighted to welcome an amazing team of experts from across these topics to lead the discussion, and it's my pleasure to briefly introduce them. First, we have Amy Gibson. She's the Chief Operating Officer for the Patient-Centered Primary Care Collaborative, a group dedicated to advancing an effective and efficient health system built on a strong foundation of primary care and the patient-centered medical home. Then we have Vojta. She's a Senior Vice President for Business Initiatives and Clinical Affairs at United Health Group and the Chief Clinical Officer of the Diabetes Prevention and Control Alliance. As a member of the core leadership group, Dr. Vojta identifies innovative solutions in the marketplace addressing significant healthcare challenges facing our nation, such as chronic diseases. Next, we have Dave Bronkart, better known to many of us as ePatient Dave, who beat stage 4 cancer in 2007, became a world-renowned blogger, keynote speaker, and health policy advisor. Dave has also co-founded the Society for Participatory Medicine and is now actively engaged in opening up healthcare information directly to patients on an unprecedented level, or as he likes to say, give me my damn data. Finally, our guest for today's hangout, James Spika. James is a medical home quality manager with Cornerstone Healthcare in North Carolina and has been recognized by the National Committee on Quality Assurance as a certified patient-centered medical home content expert. His interests are widespread, including empowering patients and families, as well as community-based delivery of primary care. And it was an honor for James to also be part of the Great Challenges team that recently met in Washington, D.C. as part of the TEDMED conference. And welcome everyone to this session. And actually, to get the dialogue started, I'd love to first turn back to James. James, you were on site this year at the Great Challenges Day. Would you share with us a bit about the day and your key takeaways from the participation?
Sure. Thanks, everyone, for joining. Great Challenges Day was particularly sought after at TEDMED, and I can tell you from being in there in the big circle of Great Challenges, everyone kind of wanted to participate after seeing everything. It was an opportunity for delegates to break off into 20 small groups to discuss 20 great challenges of healthcare. And interestingly enough, we started the day with workshops, and I thought to myself, man, this is going to be just like another main stage day at TEDMED. And I was surprised when we broke off into groups, and it was something entirely different. And during TEDMED, they encourage socializing and connecting with other delegates. You meet on a social level, but you rarely have time to dive into a particular topic. And so Great Challenges was kind of that bridge. And in my group in particular, we had some fantastic individuals that were highly accomplished and shared great insight into the particular challenge. And it kind of clicked for me that this is what I was looking for from TEDMED. I had heard great stories on the main stage, and they were moving personal stories that dug out deep emotions and created a sense of urgency that something needed to change. And the takeaway from Great Challenges was really to have that one action item or several action items from the 20 Great Challenges to come back and bring back to the TEDMED community. And so I was excited to be a part of it, and yeah, it was a great experience.
Great. Great, that's wonderful. So James, we'll probably circle back with you with some other kind of insights that you might have gained from there. I want to turn to Amy now. Amy, your organization, the Patient-Centered Primary Care Collaborative, has really been spending a lot of time looking at how we can better kind of facilitate coordination in chronic care for patients. And in particular, I know that recently with the passage of the Affordable Care Act, we've seen a number of opportunities to help put patients at the center of their care. Can you tell us a little bit more about what patients can expect, given that we're starting to implement and see some of Obamacare come into reality?
Well, that's right, Kavita, and I think one of the most exciting things that's happened as part of the Affordable Care Act is getting patients engaged in improving the overall system of care in a lot of different ways. So at the policy level, at the actual health system level, and then at that individual point of care. More than ever, I think we have these exciting times and opportunities to really engage with patients in a way that we can really learn from them. So when you're talking specifically about the needs of patients with chronic conditions, you know, those are patients who are really testing the system. They're the ones who are really figuring out what's working and what's not working. And as we engage with them and really have active partnerships with them on how to do a better job at that, how to help patients better navigate the system, coordinate their care, and really involve them as active partners in the care, I think we're going to have much better results than we've ever had in the past, as we're really putting much more value on the experience of all those individual patients and the care that they're receiving.
Great, thank you so much. Deneen, that's a nice segue to you. I know that a lot of your work has been in the complex management and the innovative solutions around these chronic diseases. Tell us a little bit, every time we start talking about patients and putting patients at the center, there are a number of questions from our Facebook users as well as others in social media who bring up the issue of data and how all this complex kind of coordination and these different streams of data have an impact on patients' privacy, as well as efforts that we might have, or what you might be seeing at United, to try to coordinate some of the data into something that a patient can actually see and benefit from?
Well, I think that that's a terrific question, and I think that the healthcare community in many ways is far behind where consumers are today. So, and even sort of that sometimes uncomfortable conversation, are we patients or am I a consumer? I'm going to argue I'm both, but it's the intersection that gives people the willies. And so for example, there may be a physician who's treating somebody with prediabetes and diabetes, is trying to encourage healthy activity and eating, and tells their patient, or the health plan tells the consumer that tracking is critical, and I say, okay, that's great, and I'm going to wear my Jawbone or my Fitbit, and you know what, I want you to have that data. So that's my personal data on my movement or on my sleep, and I want to send it to my physician or send it to the health plan or link it to a program one of those entities may have. At what point does that personal data jump over to healthcare data? And where are the to ensure, I mean, first and foremost, we have a legal and a moral obligation to make sure that it's all HIPAA compliant, etc. But what's interesting is to watch how much personal data that feels healthy people are willing to release in support of their overall health. And I think that transparency will always be Trump and be king, and that as long as folks are comfortable sending their physicians information from their Fitbit, that's going to have to be okay, and we're just in the background going to have to figure out how to make that work.
Great, thank you. Dave, I know that you probably, if you want to, you may add a comment about the data piece, but I'd love to actually also get you to give us some of your insights on how patients can, what opportunities can be offered to not only patients, but their loved ones, their family and friends, who may also want to participate in the care of these chronic conditions right now.
Well, I think underlying the answer to both is this fundamental question of, for whose benefit are we doing this in the first place? I mean, I get so irritated when I'll use the term HIPAA Nazi tells me I can't have a copy of my data for my own good. You know, it's like somebody needs to be strangled and told to rethink. You know, that we talk about the problems that arise in medicine because of overly paternalistic thinking on the part of doctors. There's overly paternalistic thinking on the part of privacy advocates also. It's my freaking data. I mean, I got an x-ray yesterday for a sore foot. They won't give me a copy of the radiologist's report, you know, so that I can look at it. My wife's a veterinarian. They gave me the x-ray. They just won't give me a copy of the radiologist's report. And I assert that a core dysfunction of this industry compared to any other is that so many of the policies and so much of the culture views the patient and their caregivers as sort of the car in the car wash that you spray things on and do things to, you know, and it's just outdated. The paternalistic metaphor is, so a week ago today, I became a grandfather for the first time, so I know what a newborn is and how helpless that child is and how everything needs to be done for her. I also know from remembering my daughter's upbringing that she was in the back seat, rear facing for the first couple of years, and then at some point we got to the point where I said, where would you like to go today? And eventually we got to the point where she did the driving, you know, and what we're seeing is it's a mistake to think of patients as the people who need to be kept facing backwards in the back seat. So,
that's great. I love the fact that you not only got to tie that into your recent congratulations as a grandfather, but to tie it back into kind of what we all have something in common as patients. We all started off in the exact same spot. So,
and this is why my call to action at the end of my TED Talk and the title of my book is not patients know everything, but it's let patients help.
Right, absolutely. So James, you are doing this work at Cornerstone, kind of, you know, and thinking also as a national expert on medical homes. Tell us a little bit about when you think about whether it's certification or some of the accreditation that medical homes are dealing with. Can you tell us what you're seeing around the country or even in your own backyard about whether patients really are being put at the center of their care, and maybe tie this back to those patients that have complex chronic conditions?
Sure. So what I'm noticing, I work in primary care for a large multi-specialty group practice, and what we see is certification is basically just a foundation. So you can get NCQA, patient-centered medical home recognition, but really that just says that you have the structure for a patient-centered medical home. Doesn't necessarily mean that you're providing everything for all the patients or that they're truly getting patient-centered care. What we've noticed here at Cornerstone is we kind of have to take it a step further. So it's PCMH 2.0, and you know, really try to engage patients and not just have those standards from PCMH there in place, but also act on them and involve people in their care. How that ties back to managing patients with chronic diseases and illnesses, it really makes it so that the patient can kind of say, this is what I want. And I think that's part of what we're looking for in patient-centered care, is for patients to own their disease and to really set goals for themselves, and not just goals of, you know, I have diabetes and I want my hemoglobin A1C level to be less than 9. It's, you know, I have diabetes and I want to make sure that in the next couple months I'm able to walk, you know, my daughter down the aisle for graduation or whatever it is. It's really getting to the core of what the patient wants. And so I think the movement for patient-centered medical home has been a lot of a buzzword for many organizations, and they haven't really fully implemented PCMH. I think just getting recognition is a great step, and it's a step in the right direction, but it's not the be-all, end-all for saying that you're truly doing patient-centered care.
Right, great. And Deneen, I wanted to make sure if you had a chance to follow up on something that either Dave or James said.
Sure. So, Dave, ePatient Dave, I could, you know, in many ways you are preaching to the choir in that it is, you know, as we look at sort of as things are developed in sort of this space, what I'm seeing is, you know, there'll be a single app, and that app is sort of siloed and living somewhere. And yet, you know, when we did a lot of research with real patients and consumers, whatever you want to call us, when we were starting with the diabetes prevention program, the diabetes prevention and control program, we kept waiting for the privacy question to come up, blinded questions, and I could see that the facilitator was getting frustrated because, and all of a sudden he said, "Isn't anybody concerned about privacy?" And I had to laugh. I thought, you know what, you're not supposed to lead the witness. And it just didn't come up. And in fact, what we found was people said the exact opposite. They said, well, I have information here, my Fitbit and my Jawbone and my doctor's office, and how come it can't all come together? And I want to share it with my family and my doctor, etc. But I think the savior here will not be the healthcare system, but it will be technology. If you look at what Robert Wood Johnson, I know is funding Open mHealth, ultimately consumers will vote with technology like that.
Amy, did you have something you wanted to add to that string of thoughts?
Yeah, I think it was so profound what you were saying in terms of how practices, especially primary care practices that are working to really create this infrastructure and change the way they practice care, provides that foundation and the supports for what they really want to end up being able to accomplish, which is more individualized care. I think we've been in this place where we've made a lot of assumptions and judgments about what patients can or can't handle, what they need, what they don't need, and specifically to Dave's reference in terms of even lab reports. You know, there's a lot of people that say, oh, well, we can't give them their lab information because they won't understand it, and they might jump to conclusions. We need to sit here and explain it to them. Well, there's a lot of patients who might be very proficient at reading a laboratory report. So I think we need to be asking patients and then asking them what kind of information they want, how they want to receive that information, how they can share that information with others, and then really use those technologies and other systems that are in place to be able to fulfill those wishes of individual patients and families.
All right, Dave, you had one last point on this you wanted to make, and then I wanted to turn to a new question.
Well, it really, you know, if you want to understand what patient-centered care is, all you have to do is look at it from the patient's perspective. And Laura Adams, a well-known doctor in Rhode Island involved in quality work, said a while ago at a conference last year, she has a patient who said to her as he was signing some sort of stupid HIPAA release form, "You asked my permission to share my data with another doctor. You ought to ask permission to not share it and keep it to yourself."
Great. That's a great final point, and we can revisit this if folks on YouTube or in Google Plus want to send us more questions about this. So keep some of these questions coming in. We actually have a question from Facebook user Sue who asked, "Doctors appear to have little regard for research when it is presented to them by patients. How can we address that?" James, would you like to take the first crack at that question?
Yeah, that's great. So this question kind of ties back into what we were talking about with health apps and patients using health applications for data, and also bringing new research to providers. And I just wanted to reference that Pritpal Tamber gave a great 4-minute talk at TEDMED on provider trust and doubt. And my experience kind of resonates with what he described. And what he's saying is that providers are taught a lot of behaviors in medical school, and naturally they're skeptical of new information that they personally have not established as being valid. And we kind of have to think about it as the traditional role of the provider was to be that medical expert. So when they're presented with new research, it can be kind of like, oh, it's outside of my web of trust, and I can't look at this, I can't accept it. And so in order to move forward past that, we kind of have to change the provider behavior and perception, and that's a really difficult thing to do. I work with primary care providers every day, and I can tell you from experience that there's not a lot of change that happens very rapidly, and especially when we're talking about changing behaviors and perceptions. But you know, one of the things that the Commonwealth Fund put out is that it takes about 9 years for a practice to implement evidence-based care and change. So if you're thinking about as a patient bringing up new research, you know, for that provider, it may take them several years for them to finally want to look at that evidence and apply it to their practice. So I think that while it's good to push providers to want to, you know, accept new research and do different things. I think at the same time we have to understand and be patient at the same time. And I know that's kind of off what we're talking about with patients, but
no, that's okay. Actually, it takes about it actually takes about 20 years for research that's published to then kind of get integrated into the very common fabric of what we do in medicine. So it's almost twice as long just to even get something that comes out in a journal today into the common practice. And I'll just say, you know, in my primary care practice, I'm booked. I've got a patient every 15 minutes. By the time they get into the room, we've all heard of this same kind of story that you have 7 to 8 minutes face to face. So I know a lot of doctors who they totally acknowledge that they can't learn or know absolutely everything in science, but they're starting to feel that once they're in the room, they've got about 7 minutes, and they need to handle, especially if you have a patient with 3 or 4 problems, it can get, it can add up. So I actually think some of the beauties of better care coordination models like the patient-centered medical home, like telehealth, like using remote technologies in healthcare, it can help in dealing with the time crunch that makes all the more stress when you feel like a patient's coming to you with articles or printouts from the internet. Anybody else want to, Dave or Deneen, any comments from you on this topic?
Well, I've said in a number of speeches that, in my view, some people say the doctor doesn't have time to evaluate these things. Indeed, who says it has to be an MD? Everybody's supposed to operate at the top of their license. My view of the medical home of the future is that there will be a person that I call an information coach, where you can submit a link, maybe by email, maybe in a live chat, say, hey, what do you think about this? Doesn't have to be an MD,
Amy, did you have something you wanted to talk about related to work you've seen at the PCPCC?
Right. I think, a lot of people focus on just the role of the physician, but what's so exciting, too, about medical home is we talk about care within a team. So we try to really expand upon all those different professionals who are part of that team, and also bringing the patient and the family in as key components of that team, because everyone brings different levels of expertise and education and experiences that can really help improve the overall care of that patient. So we shouldn't think that all of this extra work and burden has to fall on the backs of one individual. It's really got to be a partnership across the entire practice team.
And my only comment would be that for every one patient that brings in the article and wants to talk about the latest research, there are 5 others in that same day who have done the same homework but are less likely to actually mention it. And in many ways, when I practice pediatric ER, at the end of every visit, we'd go over discharge instructions, and I'd say, are you going to fill this prescription, or are you going to do, steps 1, 2, and 3? And I was always made me chuckle when somebody would say no. And then I'd say, okay, let's stop for a minute, let's talk about why not. And, very often they'd say, well, I did this research, and, I don't trust that drug, or I'm worried about this. And, I know we always talk about the 7 to 8 minutes, but the reality is sometimes it's 2 minutes or 3 minutes, and you get to a yes, and everybody's satisfied with that encounter. But sometimes the answer is no, and we have to be open to either subsequent, let's follow up and let me look into this and get back to you, and that's okay too, and that's something I think we all have to become comfortable with. Or, that patient gets 10 minutes.
Great. So let's go to another question that came in over TEDMED.com. And it ties in a little bit to some of the topics we've alluded to, but I'll ask it outright. TEDMED.com commenter Dave asks, are providers going to agree to the usage of mobile, and I assume he means mobile technology, for consultation? And in particular, are there some implications around the new technologies like Google Glass for healthcare in the treatment and partnering of patients in treatment of chronic diseases? I'll see if any of you want to take that right off the top of the bat. Any thoughts about providers using mobile technologies and some of the emerging technologies for use in treatment of chronic conditions?
Sure. Well, first of all, providers aren't all the same, not by a long shot. I know many providers who are very interested in the latest, newest stuff and and others who essentially, as I think it was, maybe it was Deneen or Jim mentioned a few minutes ago, pretty much want to stick to what they were taught in school, you know. And in fact, Richard Rockefeller at Maine Health told me a year ago that he suspects that there is almost an aspect of psychological abuse and PTSD in the way during their training some doctors have beaten into them that they'll do things a certain way and they end up rigid and not wanting to do new things. But younger doctors are more likely to do that. And the perverse thing that I think a lot of medicine needs to be aware of is, as with any other disruption where competence ends up leaking into the consumer's hands, is if the establishment doesn't get on board, they end up getting left behind, because a new ecosystem of capabilities will grow up, ecosystem of capabilities and data that the establishment isn't connected to.
I've seen just an incredible, and it's been interesting because it's not just the younger physicians. I've seen, you know, it's cycles of acceptance. Once people kind of find that having these access to these technologies can help them in management of care, it's much more comfortable. I'll just point out that one problem that we struggle with is still kind of something Deneen touched on. We have all these streams of data, Fitbit, et cetera. In my electronic medical record right now, which is pretty darn sophisticated, I actually cannot put in remote health technology or information that does not come from within the system. And I think there's some, you know, that's an easy technological fix. A lot of people know how to solve that problem, but we still face these increasing hurdles to kind of get there. So, James, you wanted to make a comment about this?
Yeah, and I'll just add on to what you said too. The other problem from that perspective is how we collect that information for data purposes too. So how do you look at technology and data that you get from a Fitbit and say, okay, well, by using a Fitbit, they're improving over somebody else in an EMR system for analytics. But for the commenter that had asked about mobile, using mobile for consultation, I met a doctor who's actually here in North Carolina, and she runs a practice called Unorthodox, and she actually does, she calls herself the MD for entrepreneurs, but she actually runs a concierge medicine practice, and she's able to do clinical services for patients if they live in North Carolina, but she's limited because she has to do a face-to-face. So it's not totally mobile healthcare, and so sometimes, you know, there may be a desire to do it, but, you know, they face problems with policy or reimbursement issues as far as, you know, telemedicine or other things. That's
pretty common. There are a lot of people who really would like to do more of this, and while we still live in a system where we're paid only for face-to-face visits and only in these clinic settings, it can become extremely limited. So we have two Facebook user questions that are related, so I'm going to try to collapse them. And I'm going to ask Deneen, I'm going to ask you if you have seen any evidence of the integration of medical interpreters along with patients and providers in the care of chronic diseases. Might be in the ambulatory or in the inpatient setting, but we've had a question around that from Facebook user Kathy, and then we had a question related to that I'll get to in a second. But Deneen, can you tell us about any partnerships or integration you've seen between interpreters and the rest of the care team?
I assume you mean language interpreters?
I think that's what she means when I do think it's language that she's alluding to in the question from Facebook, yes.
Yeah, I think this is, I hope that all of the experimentation and progression we've made with patient-centered medical home will address this issue. I'm not sure many people are out there thinking about it in a way that we must get to. All of us who are clinicians on this call, whether we're participating or listening, have been in the situation where you ask an interpreter a question, the patient goes on for about 2 minutes, and the interpreter turns back to you and says, no. She said no. Right. And we laugh and say, okay, she said a lot more, and what's around that? And if we want to make this care individualized and personalized, and we have to understand what happened. And this, again, I hate to keep going back to technology, but my hope would be that eventually that's a human decision that was just made. that eventually we can use technology to have the patient be able to answer in their own way, and I'm able to hear it in a way that we are, quote, speaking the same language, but that I can also pick up the cultural and other cues, but I am not aware of any large-scale effort to do such.
And this is related. People have been wondering how language choice, socioeconomic differences, religious preferences, some of the things that make us kind of very unique as individuals, how is that integrated, or how have you seen models, this is for all the panelists, how have you seen care really kind of honor some of those individual choices, differences, and what makes us unique?
Well, I think going back to the whole idea of building out your team and looking at the population that's being served, there's another really exciting opportunity there. So many clinics, especially federally qualified health centers, are bringing in community health workers. These are individuals who live in the community. They reflect the individuals who are being served by that clinic, and they can really identify some of those potential barriers or challenges that are going on and help communicate to those patients in a way that the clinicians might not be able to who don't live in that community. I worked in practices in Nebraska in pediatrics where we had large populations of children who had special health care needs and other types of disabilities, and a lot of the questions they were coming to the practice with dealt with issues they were facing in the school system. Well, the clinicians were not trained or educated or in any way prepared to help them address those concerns, and they were directly related to the health and the medical needs of those kids in the schools. So what we ended up doing was hiring other parents of kids with special health care needs, actually embedded them into the practice, and they did a lot of the care coordination and helped families access resources, provided a lot of that peer support, and it really made the clinicians feel that the overall visit and the time with those families was much more valuable because they were able to focus 100% on what they were experts in, on the medical condition, and then they had these other experts in the practice who were really lay people, but they were trained in a way that they could really support the patients and the families that were coming in a way they hadn't been able to before.
Dave, did you want to add to that?
Nope.
Oh, okay.
I can add to that if you want.
James, go ahead.
So I definitely agree. Bringing in community health workers or people that are in the community that can speak the language and really do that is important for understanding the culture behind it. The other thing that I find is that oftentimes you can't have everyone that you need in the room at the same time. So I think having the family and the patient available to have an honest conversation with the provider is really important. You know, we may have a religious belief or a cultural belief, and we have an impression of what that means in our mind or what we learn from a diversity class in healthcare, but really it may differ for each population. You know, not everybody practices as strict, and so really it's going to be based on that individual patient and their family and what their preferences are. So I think it's going to be kind of up to that clinical care team. And the patient-centered medical home model really looks at this and wants you to be able to assess patient needs and kind of assess what their cultural values are and what they need from the care.
Deneen?
Yeah, so first of all, Amy, thank you for broadening my thinking. I was getting so literal on the translation, but your comment made me realize that, you know, I think this issue will be ultimately what drives community-based services into the healthcare financing system. And let me give you a concrete example. Dave had commented earlier about operating at the top of your license. When we look at the diabetes prevention program, and as you know, that original research was done by clinicians, and then subsequent translations showed that in communities, well-trained health coaches, non-clinical health coaches, can deliver that program just as effectively and at far lower cost than the clinical community. And so you're seeing now across the nation, I think in about 40 states, the DPP is offered at the YMCA and other community-based programs, and they're being paid as a claim, and that's critical. So they have entered the healthcare financing system. But people in the beginning said, will this group get as good, when you scale it, will this group be able to produce as good results as the, quote, clinicians? And I said, they're going to get better results. Mm-hmm. And they're going to get better results for two reasons. One, they're getting paid for performance. But two, I said, these are generally culturally matched people. And so I will never understand what it's like to walk in the shoes of, you know, Mrs. Jones that lives, you know, on the other side of the country or grew up in a different environment, even if you, quote, translate into, you know, English for me. And yet a peer-matched coach really understands those nuances. And I will tell you, after 3 years of this program, our data is showing just that culturally matched people can deliver a clinical intervention as long as they're monitored and well-trained, and in fact get better results, and probably because of that cultural match.
There are two clinics, one the Special Care Center within Atlantic Care in Atlantic City, New Jersey, and then Dr. Jeff Brenner in Camden, New Jersey, who received a lot of attention in the Tulgawande Hotspotters article. Both of those clinics they've actually had patients who have, you know, had either been unemployed or in other jobs and wanted to transition to jobs inside of healthcare. They've actually had success in helping to train and certify patients as community health workers, and the feedback they receive is that it's exactly what you said, Deneen and Amy, that people really love having the ability to walk into where they receive care and then to actually see somebody whom they recognize. And you would think that would raise issues of privacy or some, you know, concerns, but it did the exact opposite. People were much more comfortable and at ease, and then it also helped to really distribute all the workload for getting the right care to the right patient at the right time amongst several members, and it's not just, you know, the responsibility of one person or the, you know, the doctor. And I think that's, you know, we are seeing now more and more of these models in urban, rural, large, small, onesie, twosie practices, and I think it's a tremendous growth opportunity. All right, we're going to shift gears a little bit to another question, and Dave, I'm going to ask you to tee up the answer. Is there a conflict between empowering patients and honoring the expertise and authority of medical professionals? And if so, what are the trade-offs and how do we strike a balance?
Well, you know, the reason this one called to me is a year and a half ago, I gave a talk in Jerusalem, of all things, at a meeting of the Israel Internet Society. My best friend is an Israeli intellectual, so I know very well that culture of banging heads on who has thought this out best, you know, who understands things best, and so on. And so all day long, Israeli doctors and lawyers were arguing the merits, the ethics of using the internet in medicine when its information is not tightly controlled. And there were discussions about things like Patients Like Me and ACOR and clear cases where a patient, because there's too much information for any doctor to know anymore, a patient had brought in better information than the doctor had in his or her hands. And so I got to be the last one speaking before dinner, which was delightful. And I said, look, it's no insult if a less trained person has seen something that you haven't. But there's still no substitute for the trained mind to put it into context. And what we're seeing is that in the past, before the internet, trained minds were the only place where you ever saw the latest useful information. But that's no longer true. So what we need to do is tease apart the two issues. I never go into my doctors and say, hey, stupid, why didn't you know this? I say, hey, I found this, what do you think? And that's why what we're talking about here on this hangout is partnership with patients.
Absolutely, great point. Any comments from anyone else?
Yeah, I was just going to add on that, the other thing that we have to realize is that that dynamic, that partnership between patients and providers is also changing. You know, as you mentioned, Dave, it used to be a more traditional role where the provider had a lot more information and there was limited access to resources. But, you know, it's common now, we hear about it all the time, for patients to hear something from the provider, they'll go ask their friend on Facebook or somewhere else, you know, what that means, or they'll try to get more information from Google. And we get mad as healthcare professionals because they should be asking those questions within that patient visit, but the way the current system works, they don't have time to answer them. So I feel like the transformation that's happening in primary care towards patient-centered medical homes and different transformations that are going on that allow for more time will help improve that, so that patients can ask more questions during that visit. But I think also at the same time that it's just a reality of the time that people are going to go home and put it on Facebook, or they're going to go home and they're going to talk to their friends, or research something more than just what they had within that patient visit.
All right, so somewhat related, but another question is, and something that I've been trying to consider, when we were working on the Affordable Care Act in the White House and in Congress, the topic of patient responsibility came up often. And usually it was invoked around a scenario of, I can only do so much in my clinical care. The patient has some responsibility in what their health is and what their outcomes are. And when we talk about partnerships, something that goes along with that is responsibility. But are we making reasonable or unreasonable expectations around patient responsibility in the delivery of health care?
Well, Kavita, I think that on two different points. One, we don't do a good job of informing patients about how the system works and what the expectations are on both sides. So really establishing a clear partnership and having everyone understand what their roles are as part of that care plan and decision making. The other thing is, I don't think we give patients good choices and get them invested in making those choices in a way that they can take ownership of them. So because all patients are different, they're in all different types of situations and circumstances, depending on who else is involved in their care. I mean, we need to really think about what are some various options and present them in a way so the patients clearly understand, in partnership with their families, if I choose treatment A, this will be the potential result. If I choose treatment B, this might be the potential result. And one might have core global benefits that might be greater, but I know that I can really only accomplish B. So I think I can do what's in option B, even though the overall gains may not be predicted to be as great, but if I choose option A, I'm not going to do any of them. So I think we need to think through how we're crafting those choices and decisions and involving them in that process.
Great point. Any other thoughts about patient responsibility?
So this is Deneen. A few years ago, you may recall, there was a nice Health Affairs article showing that though people living with chronic disease paid more in the form of out-of-pocket expenses compared to those of us without chronic disease. Mm-hmm. And, the bell that was rung was, this doesn't feel fair. We all have the same premiums, especially in group insurance, but, if I have out-of-pocket expense, I'm paying more. And so we created something called the Diabetes Health Plan. And what it said was, if you have diabetes and you follow evidence-based care, on the process perspective, not the outcome. So you get your labs checked, you get your eyes checked per standards of care. We will remove those co-pays. And it was interesting because people really said, employees said generally, whether or not they had diabetes, that seems fair. That the patient is now participating in their care, and if they do, there should be some financial reward. Because certainly they'll be in better health. And yet what was fascinating is that in general compliance went up about 20%. Now that's really pretty good. Some people said, well, they were surprised it wasn't higher. People are still going to choose to do what they want to do. It's their condition. But we did want to sort of, more than anything else, obviously address the financial issues, but also just heighten the awareness that if you are living with diabetes, everything you do every day matters. You only see the clinician, 4 times a year, ideally, and yet we need to engage you and understand that you are Dr. You, and you're in the best position to take care of you, and we hope the financial incentive helps.
Yeah. I have a comment to build on that. We often forget that the patient has a life outside of that medical visit. And so if you're managing a chronic disease, you live with that disease day in and day out. And as Amy stated, we have to set goals with patients that are going to be ones that they can obtain and really have that, collaborative conversation that extends past that, just that one office visit. And I think that's what we're seeing with more coordinated care through PCMH and other efforts that are going on, that patients have more access to resources outside of that smaller visit window.
And when you first asked the question, what occurred to me is, reflecting what Amy said, I sometimes refer to this as we have to get new dancing lessons to learn how to do this new kind of partnership where each person's roles are different, and we just, to a large extent, we don't know how to do that yet. We're not really good at introducing the ordinary person that you bump into in the supermarket checkout line to these new expectations. And I hear of people finding things, finding ways to do it, but that's an area where it'd be really good to collect some best practices.
So not only collecting best practices, but I think also kind of busting these myths. Sometimes I worry that people use or think about the concepts of patient responsibility like, oh, well, it's not a partnership, but it's their problem. So, or it's my problem. And I think really getting at, what we're all here to talk about today is a true partnership, which means, yes, we share some responsibility, but I like to think about it the same way we think about shared decision making, which is, in my mind, like one of the most important tools that we can have to have conversations as well as really informed, truly informed dialogues around our treatment and care options. And when I see people using shared decision-making tools in practice with patients, it really is a partnership. It's not, let me just tell you what I think and then hear your reaction. It's, here's the information, here's what I know, but then here's what we should learn together. And that's the patient talking, because they've been able to bring the information after looking at the evidence from a patient-centered point of view. So I think that when we talk about the PCMH, the team-based model, I think shared decision-making and real kind of partnerships in communication are a huge, and I know that the Affordable Care Act had some provisions around that, but I think those are huge kind of what we like to call game changers in healthcare. I think it's a huge opportunity to really move the needle. So, all right, I'm going to do a time check. We've got about 15 minutes left, so I want to get to some of the other questions that we have. And then we talked a little bit about patients with complex conditions and other language issues, personal preferences. I want to talk a little bit about patients with disabilities or special needs. Patients with disabilities or special needs in our current system often feel misunderstood or unrepresented by their healthcare providers who might not be familiar with their concerns. Tell me if any of you have seen any promising examples or any ideas that come to mind in how we can be more patient-centered for populations with disabilities or with special needs.
Well, one of the things that we used to do is when we were working in practices and helping them transform to patient-centered medical home is we would ask the clinicians, who are the patients who use your practice the most frequently? And those quite often are those with multiple medical diagnoses, often disabilities. And we ask them to then invite their families to join the quality improvement team within the practice. They were active partners helping them identify, again, where the system was working, where they could make improvements, and they're quite often the patients who really want to help the practice and make it better for everybody else. So those are the ones that I think that there's often a missed opportunity in really just going directly to those patients, reaching out to them, and asking them directly, how can we make this better for you?
Yeah, just go directly to the, we talk around it, but maybe we should actually just have these conversations and say, how would you change, I don't know if any of you saw a video called Rolling. It was done by Gretchen Berland, I think is her last name. She was a neurologist from, at the time at UCLA, then Yale University, where she is now, and she basically put cameras into, she had a lot of patients who were either quadriplegic, paraplegic, or had spine injuries returning from Iraq and Afghanistan, and she put a camera into their hands when they went to their clinics or in any interaction with the healthcare system. And it's not until you see it from their point of view that you understand, even for those of us who like to think that we are informed and respectful and patient-centered, just how dysfunctional the system can be. And it really took literally kind of rolling in their shoes and in their wheels to understand that. So Amy, I couldn't agree with you more. Any other comments or thoughts about that? question in particular?
Well, another item that's related to that, but Michael Graves, the famous architect who's now involved in redesigning hospital rooms and so on, talks about how when he wheelchaired himself into the bathroom in his own hospital room, the spigots were where he couldn't get at them, and the electrical outlets were in places he couldn't reach. And I mean, how difficult is it, to do that? And our friend Pat Masters has a new book called Designed to Survive, and she starts it, and this is not just a cute story, I really want people to think about this. She starts it with the story of finding a dead mouse in her swimming pool almost every day, and when she finally got into the pool and looked at things from the perspective of a hapless animal that tumbled in, she realized there was no way to get out. She took a styrofoam cooler lid and tethered it to the side, and from that point on, there were no more dead animals in the pool. If you really get into the position of the ultimate stakeholder, the patient, you can see things newly.
Absolutely. So we're coming to, oh, and then James, you have another book that you wanted, or is it Pat's book, Designed to Survive?
Yeah, that's Pat's book.
Okay, great. Okay, great. Good. I want to make sure we get a plug in for the title, because she's definitely worth reading. So I'm going to do kind of a quick question, and then we've got a closing question. A lot of people are using social media to watch this right now. How can social media be used to improve people's health and health care in the partnerships that we would like to see?
Very quickly, I've got a slide that I use in my talks that shows like a web of connections between people, and the point that I make is that the little dotted lines connecting people on those webs are like capillaries, and information in medicine is like a nutrient. It fuels a better outcome, and what's happening today with social media is there is far more frictionless capillary flow of information. We need to learn how to purify it and take better advantage of it, not shut it down.
I was going to comment on that too. I actually stayed up late last night, and I was on Twitter, and I was tweeting with a couple of different people about running quality improvement projects through tweet chats. And it was interesting because we talked about how we can take like an improvement project that may take days to complete and condense it down because we're all talking at the same time and we're able to collaborate in real time, and other people are able to chime in and read the conversations and give their points of view and reference. And that's just one thing, we're looking at trying to come out with actionable items that how we can improve healthcare for these people that were involved. The other avenue for social media that I've been involved in is I've been able to sit there and listen to people like Amanda, who is at LA Lupus Lady on Twitter, give advice to other patients that have lupus, and she encourages people, and it's really creating that network for people, and that's a really powerful tool for a lot of people who can't get out there maybe and interact with other people.
Any other thoughts on social media? All right, well, we're going to move to we're coming to the end of our time together, so I want to make sure that we wrap this up. This has been a great discussion, and what I'd like to do is we've heard everything from some of the challenges and barriers, often barriers that are myths and can be knocked down, like the HIPAA Nazi and the HIPAA privacy people that David referred to, through Deneen, your powerful examples in chronic care with diabetics and the results you're seeing in a short amount of time. James, your work at Cornerstone in the backyards in North Carolina, but all throughout the country, and just your recent comment about social media. It helps us unite people not only in your local area, but across the world who are struggling with this. And then Amy, for your thoughtful work in the Patient-Centered Primary Care Collaborative. And I didn't get to mention this, but what's unique about what you're doing at the PCPCC is not only partnerships with patients, but partnerships across the stakeholder spectrum. So thank you to each of you for your comments. I want to close with the final question, and we don't have too much time. I'm going to say something that hopefully I'll have an answer for this and I can kick it off, but not to overthink this. But we want to ask each of our power panelists through the great challenges discussions that we're seeing center around issues. We know that we can't solve these issues with a magic bullet or a one-shot cure or policy, but we can, and already today I think we've identified some smaller, important, but maybe less magical steps that can have a significant impact. So to each of you, what is an example of a related but small-scale hurdle that we could resolve within the next year to 5 years that helps us pursue the true partnership with patients? And I'll answer briefly. One hurdle that I think we must overcome is the ability to integrate payment for taking care and being partners with patients outside of the traditional clinic settings. So having a way to actually tie the dollars, the trillions of dollars we spend in healthcare, to go where patients are, in their homes, in their workplace, in places where it's comfortable and convenient, and you can have a dialogue over, you can do it over Twitter, you could do it over a phone, you can do it in ways that are comfortable, but have that be understood and honored by the way we actually pay for services. And I actually don't think that's too far out of our reach. So that's, I'll do that. And then Amy, I'm going to go in order of our panelists. Amy, I'd like to ask you any solutions you might have for the next year to 5 years.
Well, because we do have so much exciting work going on within primary care practices and they are working to become medical homes, I think if every single primary care practice who was working to do this would invite patients from the practice onto their quality improvement team, they would see drastic improvements, leaps and bounds improvements in the overall care that clinic is providing to the entire population of patients. So I think that's something that's really an easy thing to do, and you get some really rapid rewards by doing that.
Great, thank you. Deneen.
So yours is actually very similar to mine, and my 1 to 5 year challenge would be to develop the technical architecture we need to deliver on the promise of integrating, community-based and home-based services into the financing system. I mean, we see it, with the FAA. We see it with the banking world. We even see it with the healthcare claims world. But we need that level of open architecture to pull in data in communities so that we understand what we're buying. That will be key, and also to prove it works. So no different than drugs or devices.
Great, Dave.
I'd say open notes. The Robert Wood Johnson project that demonstrated that when patients get to see the doctor's unedited visit notes from home, they do better. They're more compliant, they're more involved, everybody loves it, and all that it requires is, technologically, is just switching that on so that somebody can log in from home and see their family's visit notes. That creates patient engagement with the record. It creates awareness. I know from my own experience, as somebody who's involved in that project, that I was able 2 weeks after an appointment to go look there and say, what was I supposed to get followed up? And 85% of patients say that having used it, that it'll be a factor in which doctors they'll use in the future. And it's important because so often I hear complaints from providers, all this patient engagement stuff is all well and good, but patients don't understand this stuff. They don't know what's going on. Well, it's kind of abusive to keep people in the dark and then say they don't know anything.
Absolutely. Great. James, you get the last word.
Okay, awesome. So I kind of work with primary care providers, and I get to listen to interactions between clinicians and patients. And I have to say that I think one of the things that people who are listening can do today would be to just change the way that you talk to your patients and listen to what they have to say. One of the things that I love is just instead of telling and demanding the patient do certain things like, go exercise, stop eating salt, stop drinking sodas, just to ask the patient, what would you like to do? And then that kind of opens up a conversation, and it makes that deeper connection between providers and patients just by switching around the question a little bit, And I think the thing that we have to remember is that at the end of the day, we're people taking care of people. and majority of us didn't get into healthcare for any other reason other than our care and general love for people. So.
Great, that's a great note to close on. So I just wanted to thank TEDMED and the Robert Wood Johnson Foundation for helping to host this together. We had a lot of people on social media, so obviously the topic is a timely one, and we hope that this isn't the first or last of these discussions. There are many other TEDMED Google Hangouts scheduled for the Great Challenges conversations, but certainly we can keep this conversation going over social media as long as we like to. So I want to just take a moment and thank everyone. Take care.
Thank you.
Thank you.